Dr. Jyothi B is a senior consultant in the Department of Anaesthesia at Sparsh Hospital, Bangalore. Her areas of interest: difficult airway, USG-guided nerve blocks, neuroanesthesia, pediatric anesthesia, transplant, and anesthesia for robotic and bariatric surgeries. Madam, you can go ahead with your talk.
I'm Dr. Jyothi, professor from KIMS Hubli, Karnataka Institutes of Medical Science, Hubli. I'd like to thank the organizers for giving me the chance. My topic is newer local anesthetic agents and adjuvants for regional anesthesia. The currently available local anesthetic agents have limitations regarding the duration of action for the post-operative management. And now the newer long-acting local anesthetic agents have been introduced, which has predictable onset and duration of action, and with which provides maximum benefit with less side effects. These liposomes are the drug delivery system. They are unilamellar, multilamellar, or multivesicular liposomes. They are microscopic vesicles with aqueous core surrounded by the phospholipid layer. They act as the drug carriers for both ionized and non-ionized drugs to improve the delivery of the therapeutic agents at the target site. They are non-immunogenic, biodegradable, non-toxic, encapsulate both hydrophilic and hydrophobic materials to deliver the drugs. The encapsulated local anesthetics in liposome controls the delivery of drug by slow release at the target site and reduces the risk of cardiovascular and CNS toxicity. Unilar liposomes are made up of concentric lipid bilayer that surrounds the aqueous compartment. And multivesicular liposomes has closely packed vesicles responsible for longer duration of action of drugs. They are made up of biodegradable cholesterol, triglycerides, and phospholipids. Depoform. Depoform, it serves as a lipid-based carrier for bupivacaine hydrochloride. Liposomal bupivacaine approved for the use is based on this technology. It is flexible, ready-to-use delivery system designed to provide an immediate release followed by the sustained release. It is administered with a small gauge needles and pen system. It has numerous microscopic spherical polyhedral non-concentric aqueous chambers containing a drug in solution, and each chamber is separated by the lipid membrane. Liposomal bupivacaine was FDA approved in 2011 for surgical infiltration for hemorrhoidectomies and bunionectomies, and in 2015 for local surgical infiltration for TAP blocks. It's a sterile, non-pyrogenic, preservative-free aqueous suspension containing the bupivacaine 13.3 milligram per ml, and it is available as single dose vial 10 ml or 20 ml, 1.3%. Following the local infiltration, liposomal bupivacaine is released into plasma in two ways. Initially, plain bupivacaine is released from the liposomal bupivacaine and is systemically absorbed. Subsequently, gradual and sustained release take place. The time to reach the maximum plasma concentration is 1 hour, followed by 12 hours. The plasma level achieved following the local infiltration, this has been compared with the plain bupivacaine. In plain bupivacaine, it takes 96 hours, whereas for liposomal bupivacaine, 120 hours following after interscalene block. It is incompatible with the lignocaine and any other local anesthetics, and also when it comes in contact with the betadine, it disrupts the liposomal barrier, and the large amount of bupivacaine is released into the circulation and can lead to the toxicity. Both plain bupivacaine and liposomal bupivacaine can be administered in the same syringe simultaneously. It has to be injected slowly, and it should be diluted with a normal saline or ringer lactate, not with the distilled water. You should not repeat any other local anesthetic drug within the 72 hours following infiltration. It has to be stored at 2 to 8 degrees centigrade. It is not recommended in the age group less than 18 years, pregnancy, for epidural, intrathecal, intravascular, or regional nerve blocks except interscalene brachial plexus block. Liposomal bupivacaine was FDA approved for wound infiltration for bunionectomies, hemorrhoidectomies, TAP block, mammoplasty, total knee arthroplasty, and inguinal hernia repair. It is still under investigation for peripheral nerve block except interscalene block, intra-articular use, epidural use, and intercostal nerve block. The effectiveness of liposomal bupivacaine has been compared with placebo or other local anesthetic agents like plain bupivacaine, lidocaine, ropivacaine, etc. And they have found that there was no improvement in one of the study. It was done for the cardiothoracic surgery and vascular surgery infiltration. They did not find any improvement in the pain for up to 72 hours, and there was no alteration in the opioid consumption when compared to the bupivacaine. A multi-center study was conducted to evaluate the pharmacokinetics and safety of liposomal bupivacaine in pediatric surgery, pediatric patient aged 6 to 17 years for spine or cardiac surgery. And they found that the time to reach the maximum plasma concentration after liposomal was lower, that is 357 nanogram per ml when compared to plain bupivacaine 564 nanogram per ml. And hence the maximum plasma concentration with liposomal bupivacaine is less toxic when it is reaches the level when it is less than 2000 to 4000 nanogram per ml. As study findings led FDA approval for local infiltration of liposomal bupivacaine more than 6 years up to 4 milligram per kg. There are many contradicting results regarding the liposomal bupivacaine when they are compared with the placebo and other local anesthetic agents. And some have given a positive result, some there was no improvement in the post-operative analgesia. This is one of the article titled Liposomal Bupivacaine, Effective, Cost Effective or Costly. Here, author has summarized 2 article review by Elfed et al., which included 72 RCTs and meta-analysis by Hussain et al., following 10 years of research on clinical effectiveness of liposomal bupivacaine. Authors found that 35 to 40% RCT are high-risk bias, and studies in this review report was found to be funded by the manufacturers of liposomal bupivacaine to the authors. 12 studies were reviewed comparing the liposomal bupivacaine surgical infiltration to the placebo, or 36 studies with a bupivacaine, ropivacaine or lidocaine. 27 studies used maximum dose of liposomal bupivacaine up to 266 milligram and small doses of bupivacaine or ropivacaine. Only 6 out of 36 studies comparing surgical infiltration with liposomal bupivacaine versus bupivacaine found liposomal bupivacaine superior. Hence, authors conclude liposomal bupivacaine for surgical infiltration or peripheral nerve block, which was compared with a placebo, based on the review and meta-analysis, that current evidence failed to routine use of liposomal bupivacaine, which was found not superior over standard liposomal bupivacaine for post-operative management. And cost of each single dose of liposomal bupivacaine is $344. Coming to the another newer local anesthetic agent. It is a bupivacaine collagen implant. It is a surgically implantable bioresorbable collagen implant containing bupivacaine hydrochloride. It is FDA approved in 2021 for the placement in surgical area during open inguinal hernia repair, which provided the postoperative analgesia for up to 24 hours. It is a single dose administration containing 300 milligrams. It has 3 implants, each 100 milligram. It is white to off-white in color, lyophilized porous mixed matrices of type 1 bovine collagen. Here, the safety of SZISACON was evaluated in 11 clinical studies undergoing inguinal hernia repair. 612 patients were treated with SZISACON between 18 to 85 years, and they evaluated for the post-operative pain and other adverse effects. The safety and efficacy of bupivacaine hydrogen chloride collagen matrix was studied for the inguinal hernia repair, laparoscopic surgeries, and the patients undergoing abdominoplasty. And they found that there was a post-operative pain was there, and there was a less opioid consumption in this collagen group, and it provided post-operative pain relief for 24 to 72 hours. Saber bupivacaine, FDA approved in 2021, It is a biodegradable injectable depot system with drug delivery over days to 3 months. Saber, it is 13.2%. The components are bupivacaine 12%, sucrose acetate isobutyrate. It holds the drug and helps in the slow release of the drug. And diluent benzyl alcohol 22% reduces the viscosity of the solution. It is a 5 ml single dose which contains 660 milligram of bupivacaine. The study Saber bupivacaine study was conducted in arthroscopic surgeries for the subacromial decompression, and which was compared with placebo 5 ml, and they found that the pain intensity, IV morphine consumption, median time for first rescue morphine was less for Saber bupivacaine. To summarize, Saber bupivacaine was found to be safe and effective in abdominal surgeries, inguinal shoulder surgeries, which when it was compared with the placebo, and there was no adverse effects noted. Local anesthetic toxicity has not been observed in 876 subjects when exposed to Saber bupivacaine in clinical trials. The mean maximum plasma concentration was less than 900 nanogram per ml for all the surgeries, and time to reach the maximum concentration was 4 to 48 hours. This is another drug, the HTX011, FDA approved in 2021. It's a combination of fixed dose of bupivacaine and non-steroidal anti-inflammatory drug meloxicam in the ratio of 33:1. It's a viscous solution for management of postoperative pain. Each ml of solution contains 29.25 milligram of bupivacaine and 0.88 milligram of meloxicam. The doses available are 2.3 ml, 7 ml and 14 ml of bupivacaine meloxicam prolonged release wound solution. It is single dose needleless administration. It is applied into the surgical site following final irrigation and suction and prior to the suturing. It's a fixed dose dual acting for the prolonged release approximately 72 hours when applied to the surgical site, which are absorbed into the surrounding tissue simultaneously. Shelf life is 2 to 3 years. It should be stored below 25 degrees centigrade. And in the cases of bunionectomy, they have used up to 2.3 ml, and for open inguinal herniorrhaphy, up to 10.5 ml they have used. And this is a picture showing where they have instilled before closing the wound in the total knee arthroplasty. The efficacy of this new long-acting bupivacaine HTX01 was studied for abdominoplasty, bunionectomy, herniorrhaphy, and a TKA, and they found that it is safe, viable, where minimal opioid use was seen, and provided post-operative pain relief for up to 72 hours. Neosaxitoxin, it's a natural neurotoxic alkaloid and known as paralytic shellfish toxin. It blocks the voltage-gated sodium channel and produces local anesthesia. It is FDA approved for phase 1 investigations. Here, the drug was studied on 84 volunteers for subcutaneous injection, and they have given either of this combination, and they found that neosaxitoxin with the bupivacaine and epinephrine was reliable and provided prolonged local anesthesia. Coming to the adjuvants, adjuvants like local anesthetic, as I told earlier, it has limitations regarding the duration of action and for the post-operative pain management, and when the catheters are used for the prolonged analgesia has got some drawbacks like infections risk and displacement of the catheter. Hence the adjuvants are added to the local anesthetic to prolong the duration of action, which has synergetic effect, and only very few local adjuvants are approved by the FDA for the neuroaxial as well as peripheral neural blockade. Various adjuvants have been used like opioids, alpha-2 agonist, NMDA receptor antagonist, and midazolam, neostigmine, etc. I'll be discussing only few drugs. Hydromorphone, hydrochloride, it's a semisynthetic opioid agonist. And here the hydromorphone was compared with the intrathecal morphine for the cesarean section and hemorrhoid surgeries, and they found that it gave comparable analgesic effect. And clonidine, alpha-2 receptor antagonist, it was Popping et al. Demonstrated that high doses causes hypotension and bradycardia, and hence 0.5 microgram per kg can be used, maximum 150 microgram for peripheral neural blockade. Because of the heterogeneity of results, it is not routinely recommended for perineural use. Clonidine is the only alpha-2 agonist currently FDA approved for epidural analgesia in humans. And dexmedetomidine, it is FDA approved only for IV sedation. It is an off-label intrathecal pain medication, and meta-analysis concludes that dexmedetomidine prolongs the anesthesia and analgesia and decreases the need for rescue analgesic, and it is found to be it is superior to clonidine for regional anesthesia. Dextran, a complex branched polysaccharides, it forms the water-soluble complex with local anesthetic agents and prolongs the duration of action. It has been studied for rectospinal block and quadratus lumbar block, TAP block, etc. They either use 7% low molecular weight dextran or 8%, and they compared with epidural analgesia, and they found that in human studies the results were inconclusive and needs further studies. Dexamethasone, meta-analysis shows that it significantly prolongs the duration of blockade at the dosage of 1 to 4 milligram for the supraclavicular block who also received IV dexamethasone, and they did not find any difference in the rate of wound infection healing and hyperglycemia. It is still debated that whether the analgesia is produced by the systemic effects and anti-inflammatory effects than the direct effect on the nervous tissue. Midazolam, which acts on the benzodiazepine receptors, the translocating proteins. The cohort study was done on 1,100 patients, and they found that neuroxyl midazolam is not associated with any adverse effects when used in conventional therapeutic doses, but it is not currently recommended for use in the peripheral nerve blocks and neuroaxial block because neurotoxicity is the major concern. Ketamine and magnesium sulfate, both are NMDA receptor antagonist. They have been, we have been using intrathecally and epidurally also, but it is not FDA approved for the both intrathecal or epidural, and even for the peripheral nerve blockade. So, because of the neurotoxicity is the major concern. And to conclude, there are no adjuvants currently approved by the FDA for perineural administration. Even the most effective perineural adjuvants has moderated duration of analgesia. Low quality clinical trials like definition of analgesia and assessment protocols are not standardized or not consistent. And there are potential risks like neurotoxicity. They found that there is absence of benefits over the systemic administration and off-label use. Recent volunteer studies have shown ineffectiveness of commonly used adjuvants. Despite the drawbacks, the continuous catheter technique represents a superior option for postoperative analgesia. Thank you.